Welcome to part 2 of our comprehensive Parkinson's disease presentation. In this section, we'll focus on the critical aspects of medical management and physiotherapeutic evaluation. This builds directly on our understanding from the part 1 of the disease pathophysiology and clinical manifestations. If you need to check it out, please click the link. Today, we will explore how we diagnose, treat, and systemically assess patients with Parkinson's disease to provide an optimal care throughout their journey with a complex situation. Our objectives for the second part are comprehensive and practical. You will gain understanding of the pharmacological management approaches that form the backbone of PD treatment, including the golden standard, levodopa therapy, and its complications. We will explore deep brain stimulation as a surgical option for carefully selected patients. This will be also compared in the clinical lesson with other electrical stimulations. Most importantly, for rehabilitation professionals, we will learn to apply systemic physiotherapy evaluation techniques that capture the full spectrum of Parkinson's disease impairments. We'll cover how to select appropriate outcome measures for different stages of the disease and develop comprehensive assessment framework that guide effective treatment planning. Medical management of Parkinson's disease serves two primary goals. First, we aim to slow disease progression using neuroprotective strategies, essentially trying to preserve remaining dopaminergic neurons and delay the inevitable decline eventually. Second, we provide symptomatic treatment for both motor and non-motor symptoms to maintain a quality of life. The key challenge that every clinician faces is that managing becoming increasingly complex and difficult over time, particularly for patients with moderate to advanced disease stages, those at Hoehn Yahr stage 3 or higher. The delicate balance between the therapeutic benefits and adverse effects becomes more difficult to maintain as the disease progresses. The Hoehn Yahr Classification system provides a standardized way to stage disability in Parkinson's disease. Stage 1 represents minimal or absent disability with unilateral symptoms if present. These patients often don't even realize they have Parkinson's disease yet, while stage 2 shows minimal bilateral or midline involvements. But importantly, the balance is not yet impaired. Now, stage 3 is where we see the emergence of postural instability, impaired writing reflexes, and unsteadiness when turning or rising from the chair. Some activities become restricted, but patients can still live independently and may continue some forms of employment. Stage 4 represents severe disability with all symptoms present. Standing and walking are possible only with assistance devices, or even with help. Finally, stage 5 patients are confined to bed or wheelchair. The staging system is crucial because this provides a treatment approach and helps predict functional outcomes. Carbidopa, levodopa remains the gold standard drug therapy for Parkinson's disease, and it's been so since levodopa was first introduced in the 1961. Here's how it works. Levodopa is a dopamine precursor that can cross the blood-brain barrier. Without crossing it, the drug simply will not take its effect, something that dopamine itself will not do and cannot do. Carbidopa prevents levodopa from being converted to dopamine before it reaches the brain, so allowing more of the medication to be effective. The primary benefits are remarkable. It controls the cardinal symptoms of bradykinesia and rigidity, out of the 4, increases movement velocity, and improves strength. We describe medication states as on and off states. The on state refers to when motor symptoms have improved with the medication, typically 20 to 60 minutes after dosing. The off state is when patients experience return of tremors, resting tremor especially, akinesia, or rigidity because medication is depleted or ineffective in the later stage. Unfortunately, chronic dopamine replacement therapy comes with significant complications that emerge over time. Motor fluctuations include the wear-off phenomenon, where patients experience end-of-dose deterioration after 4 to 6 years of treatment. There's also on-off phenomenon, characterized by abrupt, random fluctuation in motor performance that can be quite distressing for the patients. Even more challenging are levodopa-induced dyskinesias, or LID, L-I-D. These are dynamic, uncontrolled movements that can be choreic, athetoid, or dystonic in nature. Peak dose dyskinesia occurs at high plasma levels when patients have maximal effects from reduced akinesia and rigidity. These movements typically affect the neck, face, trunk, upper limbs, and while diphasic dyskinesia appears during the transitions between on and off states and can significantly affect walking and balance, creating safety concerns. Beyond levodopa, we have several other classes of medications. Dopamine agonists work by directly stimulating dopamine receptors and can reduce rigidity, bradykinesia, and motor fluctuations. However, they carry a risk of impulse control disorders, problems like pathological gambling, compulsive shopping, or hypersexuality that can be devastating for patients and the families. COMT inhibitors prolong the levodopa effects by blocking its breakdown in the body, and they are particularly useful for wearing off symptoms. We also have MAO-B inhibitors, MAO-B inhibitors, anticholinergics, and amantadine, which is commonly used in ADHD treatments, each serving as adjunctive treatments for specific symptoms. Each medication has its own mechanism of action and distinct side effect profile, requiring individualized treatment approaches as well as specialized care. Deep brain stimulation. This represents a significant surgical intervention for carefully selected group. Only those selected will be proceed for this treatment. The procedure involves implanting electrodes in the brain, most commonly in the subthalamic nucleus and globus pallidus internus, where high-frequency stimulation can improve Parkinson's disease symptoms. The benefits include improved tremor and motor symptoms, especially during off periods when medications aren't working as well. However, patient selection is critical. Only 10 to 20% of the patients who are screened turn out to be good candidates. The key predictor of success is levodopa responsiveness. If symptoms don't respond to levodopa, they are unlikely to improve with DBS and may actually worsen during the stimulation. This is why a comprehensive multidisciplinary evaluation is essential before considering DBS surgery. So please ask the surgeon, specialized care provider for this method. Rehabilitation follows a therapeutic care continuum based on disease stage. In the early stage, patients are functional and independent with minimal impairments, so we focus on the fitness improvement and prevention of future problems. Recent research suggests that Early intensive exercise might actually slow motor decline and have neuroprotective effects. During the middle stage, symptoms become more apparent and activity limitations emerge. This is when comprehensive rehabilitation services show the most benefit. With exercise training programs providing effective for improving motor performance and quality of life, in the late stage, patients become more dependent in mobility and activities of daily living. So, at this later stage, our focus shifts to safety, prevention of complications, and supporting both patient and family. We use 3 types of intervention throughout: restorative approaches to improve impairments, preventative strategies to minimize complications, and compensatory techniques to modify task or environment. A comprehensive physical therapy examination for Parkinson's disease requires systemic assessment across multiple domains. We begin with thorough history taking and systems review to understand the patient's unique presentation and stage of disease. Cognitive and psychosocial function evaluation is crucial because these non-motor symptoms significantly impact treatment outcomes. Sensory and musculoskeletal assessment help us understand the full scope of impairment. Motor function and postural control testing forms the core of our neurological assessment. Finally, functional status and activity level examinations tell us how all these impairments translate into real-world problems and disability. The selection of specific tests and measures must be tailored to the patient's disease staging, severity, and individual circumstances. All of the introduced tests have very high reliability and specificity, and that's why they are recommended in the book. Cognitive assessment is essential because impairment is present from the earliest stages of the Parkinson's disease, even before medication treatment begins. The Montreal Cognitive Assessment, or we commonly call it MoCA, provides an excellent screening tool across multiple cognitive domains. We know that executive dysfunction, problems with processing speed, attention, planning, and abstract reasoning is common from early stages. Almost half of the early stage patients also show visual, spatial, and memory deficits. For psychosocial function, the statistics are quite alarming. 40% of the patients have major depression, with 55% showing subclinical depression in early stage disease. Anxiety affects 31% of the patients, and apathy occurs in 20 to 36% of the newly diagnosed individuals. We have excellent tools for assessment, include the geriatric depression scales, Hamilton Depression Rating Scale, geriatric anxiety inventory, and Parkinson's anxiety scale. Rigidity assessment requires systemic clinical examination with the patient's positioned supine or seated in a relaxed position. We move each extremity through full passive range of motion, feeling for increased resistance. Cockwell rigidity has the characteristic jerky, racket-like quality that occurs when tremor is superimposed on an increased tone. Lead pipe rigidity shows sustained resistance in all directions without fluctuations. It's important to remember that rigidity is often asymmetrical, especially in early stages of the disease. We need to document both the severity and the distribution patterns, noting which body segments are affected and how these changes throughout the time of the day or medication cycle. Significant trunk rigidity should alert us to expect deficits in functional mobility and postural reactions. Bradykinesia assessment requires both timing and observation skills. We use a stopwatch to quantify movement time, how long it takes to complete a movement, and reaction time, which is the delay between the wanting to move and actually initiating the movement. We examine the amplitude of movements and look for fluctuations throughout the task. Rapid alternating movements are particularly revealing. Tasks like finger-thumb opposition, pronation, supination, and repetitive hand opening and closing show the progressive decay in amplitude that characteristic of Parkinson's disease. Complex motor tasks like writing, dressing, skilled object manipulation are typically impaired. What's especially challenging for patients is dual tasking. Performance degrades significantly, actually, when they try to do two things at the same time, which has important implications for safety and daily function. Tremor assessment requires careful documentation of location, persistence, and severity. We need to distinguish between resting tremor, which is the classic Parkinson's disease presentation, and action tremor, which may appear as the disease progresses. The functional impact is what matters most to the patients. So we should test activities like drinking from a cup, feeding, dressing, and writing to see how tremor interferes with daily tasks. It's important to know that stress, nervousness, and excitement as well can aggravate the tremor significantly. The NDS-UPDRS provides a standardized assessment items from 3.15 to 3.18 that gives us reliable, reproducible measures. Remember that not all Parkinson's disease develop tremors, and its severity doesn't really tell or correlates to overall disease progression or disability level. Balance assessment in Parkinson's disease requires multiple clinical measures because postural control is complex and covering multiple aspects. The Berg Balance Scale is particularly valuable because it correlates well with the UPDRS and provides a very good overall measure for the function in its population. The functional reach test assesses forward reaching capacity, while the timed up and go evaluates the dynamic balance during a functional task. The dynamic gait index examines walking with changing task demands, which is often challenged faced by this population, which is particularly relevant for the PD patients as well. So the Mini-BESTest offers a more comprehensive 14-item assessment across 4 balance domains. Research has shown that these tests can discriminate between PD patients who have history of falls versus those who don't, and making them valuable for the risk assessment and treatment planning. Fall risk in Parkinson's disease is critical safety concern with sobering statistics. 70% of the PD patients report experiencing falls within the year in the past year. And 50% report recurrent falls. The fall injuries rate is about 40%, and within 10 years of diagnosis, approximately 25% of the patients will have developed a hip fracture, which can be deadly. The primary risk factors include the disease severity and postural instability, gait impairments, including the freezing episodes and non-motor symptoms like dementia and depression. Orthostatic hypotension and medication-induced dyskinesias also contribute significantly to the 4 risks. Understanding these risk factors help us targeting our intervention and provide appropriate safety education to patients and their families. Gait disturbances in PD can be divided into continuous and episodic problems. Continuous problems include 3 primary impairments. First is slowness. It affects both pace and the rhythm, caused by the combination of bradykinesia, hypokinesia, and rigidity. The second is increased variability. Patients show greater stride-to-stride variations in step width and length, which contributes to instability. Third is poor postural control during walking, affecting their ability to achieve, maintain, and restore balance while moving. Episodic problems include fascination, those unintentionally short and rapid steps, and freezing of gait. Freezing affects about 26% of the patient with mild PD, but it can drastically increase to 80% of those who are in the severe stage. Common triggers include doorways, narrow spaces, changes in flooring patterns, and dual task situations. Assessing freezing of gait presents unique challenges because of its unpredictable nature. We need to document triggers and provoking factors carefully. Common triggers include gait initiation, walking through narrow passages or doorways, turning in tight spaces, especially the ones in the Netherlands, and situations involving time pressure or increased cognitive load. The new freezing of gait questionnaire, or NFOQ, is a reliable 3-part assessment tool that includes a short video to help detect and rate the freezing severity and its impact on daily living. Understanding freezing patterns is crucial because they are strongly linked to 4 risk and significantly impact quality of life and independency. Functional assessment in PD requires standardized outcome measures that can track changes over time. The 10-meter walk test gives us both comfortable and fast walking speeds, providing insights into mobility capacity. The 6-minute walk test assesses the walking endurance, which is often compromised in Parkinson's disease due to both motor symptoms and cardiovascular deconditioning. The 5 times sit-to-stand test evaluates the functional leg strength and has been shown to discriminate between the fallers and non-fallers. The 9-hole peg test assesses the manual dexterity, which is particularly important given that the hand function problems are reported as one of the top contributors to disease burden. The activities-specific balance confidence scale measures balance confidence, which is closely related to functional mobility and fall risk. Non-motor symptom assessment is crucial because patients typically experience 8 to 13 non-motor symptoms regardless of their motor stage or disease duration. The Non-Motor Symptoms Questionnaire, or NMSQ Quest, is a 30-item screening tool that assesses the presence of these symptoms and their impact on the activities, as well as the quality of life. The Non-Motor Symptom Scale, or NMSS, goes further by assessing both frequency and severity. Research has identified 4 main symptoms clusters, including the REM sleep, rapid eye movement sleep, behavior disorder symptoms combined with constipation, cognition-related symptoms including memory complaints and fatigue, mood-related symptoms like depression and apathy, and sensory and autonomic dysfunction, including pain and excessive sweating. Comprehensive assessment of these symptoms is essential for the better and optimal patient care. Autonomic dysfunction assessment covers multiple body systems that are commonly affected in Parkinson's disease. Orthostatic hypotension is diagnosed when there's a 20 millimeter mercury drop in the systolic pressure or 10 millimeter mercury drop in diastolic pressure upon standing. This will drastically increase the fall risk and must be carefully monitored. On the other hand, the thermoregulatory functional problems include excessive sweating and abnormal temperature sensations that can be quite distressing for patients. Gastrointestinal functions are quite impaired sometimes and can be extremely common, with constipation being the early symptom and impaired gastric emptying occurring in severity to 100% of the patients. Genital urinary problems include incontinence, frequency, and urgency. Cardiovascular changes include sympathetic denervation of the heart, resulting in diminishing heart function and blunted exercise responses that contribute to the fatigue most patients experience. Fatigue assessment has become increasingly important as we recognize its significant impact on quality of life in Parkinson's disease. The Movement Disorder Society Task Force has recommended 3 primary tools. The Parkinson Fatigue Scale, or PFS-16, is a 16-item self-report measure specifically designed for Parkinson's disease that assesses physical fatigue and its impact on daily function. The Fatigue Severity Scale, or FSS, is a 9-item tool that emphasizes the functional impact of fatigue across various activities. The Multidimensional Fatigue Intervention Inventory, or MFI, is most comprehensive, and with 20 items measuring general fatigue, physical fatigue, mental fatigue as well, and reduced motivation and reduced activity. What's important to understand is that both fatigue prevalence and its impact on daily living increase as the disease worsens, making regular assessment essential. Disease-specific outcome measures provide the sensitivity needed to detect meaningful changes in Parkinson's disease. The Parkinson's Disease Questionnaire, or PDQ-39, is a 39-item quality of life assessment that emerged from in-depth interviews with Parkinson's disease patients themselves. It covers 8 crucial dimensions, including mobility, activities of daily living, emotional well-being, stigma, social support, cognition, communication, and bodily discomfort. The tool has demonstrated high internal and test-retest reliability. The MDS Unified Parkinson's Disease Rating Scale is our most comprehensive clinical ratings tool. It's divided into 4 parts. Parts 1 and 2 assesses non-motor and motor experiences of daily living. Part 3 is the motor examination with 33 scores on 18 items, and Part 4 evaluates motor complications. These standardized tools are essential for tracking disease progression and treatment effectiveness. The timing of assessments in Parkinson's disease is absolutely critical and often overlooked. We should conduct evaluations during optimal dosing cycles whenever possible to get the most accurate picture of the patient's best functional capacity. However, we also need to understand how patients function during the off states. The stability of measurements varies significantly between on and off periods. With much more reliable results during the on phase, consistency is the key here. We should perform repeat testing at the same time of the day and at the same point of the medication cycle. Motor fluctuations mean that patient's performance can vary dramatically throughout the day. So documenting these patterns helps us provide better recommendations for the timing, daily activities, and therapy sessions. Let me conclude this presentation with the key clinical implications for Parkinson's disease assessment. We must take a very comprehensive approach that addresses both motor and non-motor symptoms. The days that when we only focus on the tremor and the movement problems are long gone. Our assessment should be stage appropriate, emphasizing prevention in the early disease, restoration in the middle stages, and compensation in the advanced stages. A multidisciplinary team approach is essential, involving physical therapy, occupational therapy, speech-language pathology, psychology, and nutrition as needed. We must use a family-centered approach that includes caregivers in both assessment and treatment planning. Finally, safety and fall prevention should be a focus throughout all stages of the disease. The comprehensive assessment framework we've discussed today provides the foundation for effective, evidence-based intervention that can significantly improve outcomes and quality of life for people living with Parkinson's disease. This completes part 2 of the Parkinson's disease presentation. The systemic assessment approaches we've covered today provide the essential foundation for developing effective treatment plans that addresses the complex multidimensional nature of this condition. Thank you for your attention, and I will be very happy to answer and address any questions you may have. And this is the reference